Hi, I'm Ed Eichhorn, the co-founder of the Healing American Healthcare Coalition. Our goal is to provide our listeners and readers with timely information on pandemic research and developing universal healthcare plans for America. Our coalition is not a political action committee, nor is it affiliated with any political party. Our mission is to be a trusted, objective source regarding current national discussions on healthcare initiatives that will impact the health and well-being of all Americans. Today, I'd like to provide you with our presentation on the current status of universal healthcare proposals. So let's begin. So universal healthcare, making healthcare a right and not a privilege is what we'll discuss today. As a part of our presentation, we'll discuss Medicare For All, Medicare X that was recently reproposed by the senators from Virginia and Colorado, the American Relief Plan and how it expands the Affordable Care Act that was recently passed just this Wednesday. And we'll also cover the Eichhorn-Hutchinson plan that is a part of our book, Healing American Healthcare. First, I'd like to share a couple initial thoughts with you. In 1941, Winston Churchill was chairing a British cabinet meeting as the United Kingdom was awaiting the United States' entry into World War II or just to support Great Britain. It aptly describes a quote that applies to the status of healthcare policy today. Winston Churchill said, as one of his cabinet members was anxiously asking about when the United States would enter the conflict, that Americans will always do the right thing in the end, but only after exhausting all other possibilities. And I think that thought certainly applies to healthcare in the United States today. We've been talking about universal healthcare in our country since Teddy Roosevelt ran for presidency in 1912. And hopefully over the next few years, we can find a way to come together to develop a universal healthcare plan that would serve all Americans. I'd also like to just mention this thought from Warren Buffett that he expressed at the 2017 annual meeting of his company, Berkshire Hathaway. He said the biggest problem that U.S. businesses face in competing with overseas companies is not corporate taxes, it's the cost of healthcare. He said that over the last 50 years, as a percentage of GDP, corporate taxes have decreased from 4% to less than 2%. While the cost of healthcare has grown from 4% to 17.1%. So when we think about improving healthcare, there are three goals and one outcome that we should expect. First of all, we should provide universal healthcare. 29% of Americans don't have healthcare at this time, and another 40% are underinsured. We need to reduce healthcare's costs. We have the most expensive healthcare system in the world. Our costs are, in general, twice as much as the costs of other members of the United Nations organization called the Organization for Economic and Cooperation. We need to reduce healthcare's bureaucracy, and we need to improve medical outcomes. If we do the first three things, we have a good chance at improving our medical outcomes. Currently, our life expectancy is 3.5 years less than most countries in Europe. And it's been projected that because of the pandemic, our life expectancy projection should drop by another year on average and could drop by as much as 2 to 3 years for African American and Hispanic Americans. Today, healthcare consumes more than 17% of our GDP. And we spend about $3.4 trillion a year on healthcare in the United States. Our per capita costs, as I mentioned, are more than twice the average of capital costs of other democracies. And the Center for Medicare and Medicaid has projected that if we do nothing, these costs could double to $6.5 trillion by 2027. And now, if you look at government-funded healthcare costs today, approximately 150 million Americans have government-funded health insurance. About 70 million Americans are covered by Medicaid. 57 million Americans have Medicare coverage. 9 million Americans are covered by the Veterans Administration. Another 9 million have TRICARE, for military active duty retirees and dependents. Approximately 2 million Native Americans are covered by the American Indian Health Service. And 10,000 baby boomers sign up for Medicare every day. Medicare For All is a single-payer system, and it would eliminate the health insurance industry and up to 2 million jobs, about 1.5 million jobs in the health insurance industry, and an additional 500,000 jobs from providers like hospitals, doctors, and clinics. It would also regulate drug pricing, which is something that every plan should do. Estimates of its costs vary a great deal, from an annual increase of $3.2 trillion to an annual savings of $600 billion. Surveys indicate that Medicare for All is supported by only 38% of respondents because it eliminates choice. And in a survey of Democratic voters, initially 75% of the respondents supported Medicare for All, but 88% of the same survey group did not support it when they realized they would have to give up choice in healthcare. If Medicare for All became law, it would also likely accelerate physician retirements, increasing the projected future physician shortage. Today, 30% of our physicians are over the age of 55. And if their income was going to decline because of the prices set by Medicare for All, they may consider retirement at an earlier age. And although some aspects of Medicare for All are discussed routinely by Senator Sanders, who is the main proponent of Medicare for All and came up with a plan, it does impact hospital operating budgets. When Senator Sanders talks about his bill, he says that it's going to eliminate copays and expand Medicare to include eyeglass and hearing coverage and lower the cost of pharmaceuticals. Those are all popular with voters, but he doesn't go into what Medicare for All would do to hospital operating budgets. So let's take a look at what that process would become. The bill would require that the Department of Health and Human Services establish a national budget for hospital operations. What this means is that hospital budgets would be global budgets based on the global budgeting experiment for hospitals in Maryland that began in 2014. These are top-down budgets, not bottom-up budgets. The national budget would be rolled down to each state, and the states would determine each hospital's operating budget in their state. Health and Human Services could also dictate hospital staffing levels, and capital budgets would be handled separately. So this would be a very dynamic change if Health and Human Services could actually tell every hospital what the ratio of doctors to nurses would be in their operating budget. So if we look at this, when we began this presentation, we said we should provide universal health care, reduce healthcare's costs, reduce its bureaucracy, and improve outcomes. The Medicare for All proposal would improve outcomes and expand healthcare coverage, but it would also increase costs and would likely increase bureaucracy. Let's take a look at the Medicare Exchange or Medicare X proposal. This bill was originally introduced in the last congressional session by Senators Kaine and Bennett. They reintroduced the bill this February and had 11 co-signers for their bill. It would introduce a public option based on Medicare in those areas of the country that have a shortage of competitive private insurance plans for individuals and small business. Once that had been introduced, it would expand nationally by 2025. It would also include reduced drug prices for Medicare X and Medicare Part D. Well, let's see how that compares to how we believe we should improve healthcare. Medicare X proposals would improve outcomes and expand healthcare coverage. It would not create universal healthcare coverage. It has not been scored by the Congressional Budget Office to provide an estimate of its cost impact, so it'd be hard for us to estimate its cost. And it does not address healthcare's bureaucracy. This week, the American Relief Bill became law, and the bill expands Obamacare subsidies to higher income levels. These changes will offer coverage to an additional 1.3 million Americans. The CBO estimates that this will increase federal subsidies by about $35 billion a year. The bill provides incentives to red states to expand Medicaid coverage to Americans who are currently not eligible in these 17 states. It will lower the cost of COBRA benefits for Americans who have lost their jobs during the pandemic. Dr. Emanuel, who is a professor at the University of Pennsylvania and was a part of the team that designed Obamacare, reports that this bill will have a dramatic impact on reducing the number of uninsured Americans. These measures are also only temporary, and they will expire in 2022. So, looking at our goals for healthcare improvement, the pandemic relief bill will expand health coverage, and it will reduce the number of uninsured Americans. It will improve outcomes. This plan is a move in the right direction. However, it increases cost and does not reduce bureaucracy. Let's take a look at AllCare, a practical, affordable approach to universal health care that Dr. Hutchinson and I wrote about in our book, Healing American Healthcare. We would require all employers to provide health insurance for their employees, much like the German plan that began in Germany in 1883. Employers would have choice. They could be self-insured, provide private insurance, or AllCare for their employees. Today, 90% of private health insurance programs are sold to employers. AllCare would allow them to keep their business, unlike M4A that would eliminate their industry. AllCare would be approximately 30% less expensive than today's cost of private insurance, creating price competition. This competitive pressure could reduce the cost of insurance for companies by as much as $180 billion a year. Individuals could also purchase AllCare. Individuals or companies could purchase Medicare Advantage-like plans to provide gold and silver plans to augment AllCare to compete for employees. Today, 16% of Medicaid recipients are employed, and they would now get coverage through employers. This would reduce the cost of Medicaid for the federal and state governments by more than $200 billion per year. AllCare would also introduce a national charge master for hospitals and clinics to reduce the complications of medical billing. We estimate this would reduce the cost of billing to 5% of total healthcare costs, and it now varies between 8 and 10% of healthcare costs. AllCare would also require national drug price negotiation and would allow Medicare Part D to negotiate drug prices. AllCare could reduce the cost of healthcare in the United States by $1 trillion a year while improving access to care for everyone. So why consider AllCare to address the needs of universal healthcare in America? Well, first, it provides choice for individuals and employers, something surveys have said that all Americans want. It creates a more level playing field for employees. If every employer is required to provide insurance, Americans will be completely free to change jobs without concern for losing their healthcare benefits if they choose another employment opportunity. Employers will need to consider increasing the competitiveness of their benefits and employment practices to retain staff. It does not eliminate private insurance companies. It challenges them to compete with AllCare as the public option. It lowers the cost of coverage for AllCare and all private insurance companies by requiring national negotiation for pharmaceutical pricing, and it lowers the cost of AllCare and all private insurance companies by simplifying the bureaucracy of billing and collection. AllCare reduces the cost of Medicaid by requiring all employers to provide health insurance at a time when Medicare is adding 10,000 beneficiaries every day. AllCare also provides the opportunity to reduce the budget deficit at a time when the national deficit is growing rapidly based on the 2017 tax cut and the challenges of the pandemic that we face today. AllCare meets the challenges of the CBO projection on the growth of healthcare costs over the next several years. The other plans do not. AllCare is a concept that could help Congress to reach a strategic compromise that would result in a universal healthcare system. It reduces government costs, something that Republicans traditionally want, while providing universal healthcare, something Democrats traditionally want. AllCare builds on Obamacare's strengths. So going back to our 4 goals for healthcare improvement, by providing universal healthcare, reducing healthcare's cost, reducing bureaucracy, and therefore improving outcomes, AllCare addresses all 4 healthcare improvement goals. We'd like to take a moment to compare Medicare For All to AllCare, and we would do the same for Medicare X when its financial factors are developed. Medicare For All is paid for by taxation. AllCare is largely paid for through employment. Medicare For All eliminates the healthcare industry, and AllCare does not. Medicare For All controls all hospital budgeting. AllCare does not. Medicare For All does not address hospital markups. Medicare For All does. Medicare For All dictates doctor and nurse staffing levels for every hospital, and AllCare allows hospitals to manage themselves. Medicare For All is supported by progressive Democrats. AllCare provides an opportunity for a strategic compromise between Democrats and Republicans. So thank you. Please join our coalition at Healing American Healthcare to receive our timely newsletter, The 3-Minute Read. And to learn about the Eichhorn and Hutchinson plan, read our book, Healing American Healthcare. It's available at Amazon, Barnes & Noble, and at our website. The Healing American Healthcare podcast series is available on Spotify or at Apple. Our book is available as an ebook or a paperback. Thanks for joining us. Once again, my name is Ed Eichhorn. We appreciate your taking time to listen to our podcast.